I'm Dmitry again, and today we begin Chapter 32 of Guyton's Pocket Physiology on diuretics and kidney diseases. Again, this is from Guyton's Pocket Physiology textbook, the PDF version, and so you can follow along with either the Pocket Physiology version, which is the more condensed version, or you can follow along with your Guyton Hall standard physiology textbook. So, let's begin. Diuretics and their mechanisms of action. Diuretics increase the rate of urine volume output. Many diuretics increase urinary excretion of solutes, especially sodium and chloride, as well as urine volume. Most of the diuretics used clinically act primarily by decreasing the rate of sodium chloride reabsorption in the renal tubules, which in turn causes natriuresis, increased sodium excretion, and diuresis, increased water output. The most common clinical use of diuretics is to reduce extracellular fluid volume in diseases associated with edema and hypertension. Balance between salt and water intake and renal output occurs during chronic diuretic therapy. Some diuretics can increase urine output by more than 20-fold within a few minutes after they are administered. However, the effects of diuretics on renal output of salt and water subsides within a few days owing to activation of compensatory mechanisms initiated by decreased extracellular fluid volume. For example, reduced extracellular fluid volume decreases arterial pressure and glomerular filtration rate, GFR, and increases renin secretion and angiotensin II formation. All these responses eventually override the effect of a diuretic on urine output, and in the steady state, urine output becomes equal to intake, but only after a reduction in extracellular fluid volume has occurred. Many diuretics are available for clinical use, and they have different mechanisms of action and therefore inhibit tubular reabsorption at different sites along the renal nephron. The general classes of diuretics and their mechanisms of action are shown in Table 32.1. Let me just go check something right now. Okay. Good. And we will proceed back forward with the chapter. Kidney diseases. Severe kidney diseases can be divided into two main categories. One, acute kidney injury, AKI, in which the kidneys abruptly stop working entirely or almost entirely, but may eventually recover nearly normal function. And two, chronic kidney disease, CKD, in which a progressive loss of function of nephrons gradually decreases over all kidney function. Included within these two general, and this is a big table, I'll get back to that later. These general two categories are many specific kidney diseases that can affect the blood vessels, glomeruli, tubules, renal interstitium, and parts of the urinary tract outside the kidney. In this chapter, we discuss the physiological abnormalities that occur in a few of these most important types of kidney diseases. Diseases of the kidneys are among the most important causes of death and disability in many countries throughout the world. For example, in 2014, more than 26 million adults in the United States were estimated to have CKD, chronic kidney disease, and many more millions of people have to have acute kidney injury or less severe forms of kidney dysfunction. So this is the table right here. It says classes of diuretics, mechanism of action, tubular sites of action. So this is going back to the diuretic section. So you can see osmotic diuretics like mannitol, loop diuretics like furosemide, thiazide diuretics, chlorothiazide, carbonic anhydrase inhibitors, that'd be like acetazolamide, for example, mineralocorticoid receptor antagonists, so that'd be like spironolactone. So that's kind of, we're working with the sort of hormonal system, kind of counteracting the effects of mineralocorticoids. And also the sodium channel blockers like amiloride. Now, they explain exactly how these work right here. Let me just zoom out for a little bit if you wanted to go read each of these things. So that's the full table. You can pause the video if you want to. But I would recommend using a different study method than the physiology textbook for this, for looking at pharmacology, because it'll probably be better explained exactly how these things work. Oh, it says right here, the tubular, mainly the proximal tubule, thick ascending loop of Henle for the case of loop diuretics, that kind of thing. But I would look, if I were you, I would look at the diagram like online or something like that, or like in an anatomy textbook, or even maybe even the Guyton physiology textbook, that's the normal version, and just see the actual shape of how the nephron is, and how the glomerular, the actual overall structure of everything and how it works. And then from there, kind of, track out, okay, well, this works here, and this works here, and this transporter is here, because that's going to be a lot more easy for you to understand than just looking at a chart or like a table like this. So let me go back into this again. Okay, there we go. Yeah, I'll need to do that maybe one more time. Okay. Is this all fine and well? It looks like it, yeah. All good? Good, good. Okay, and I'll get back to it. Acute kidney injury. 3 main categories of acute kidney injury have been identified. Pre-renal acute kidney injury is caused by a decreased blood supply to the kidneys. Decreased blood supply to the kidneys can be a consequence of heart failure, which reduces cardiac output and blood pressure, or conditions associated with diminished blood volume, such as severe hemorrhage, when blood flow to the kidney decreases to less than 20% of the normal rate. The renal cells start to become hypoxic. Further decrease in flow, if prolonged, causes damage or death to the renal cells. If the acute kidney injury is not corrected, this type of failure can evolve into intrarenal AKI. Intrarenal AKI results from abnormalities in the kidney itself, including abnormalities that affect the blood vessels, glomeruli, or tubules. Acute glomerulonephritis is a type of intrarenal acute kidney injury caused by an abnormal immune reaction that causes inflammation of the glomeruli. The acute inflammation usually subsides within 2 weeks, although in some patients, many of the glomeruli are destroyed beyond repair. In a small percentage of patients, continued renal deterioration leads to progressive CKD. So that's kind of a similar situation in comparing, like, let's say, for example, angina versus MI. Let's say, for example, I have a angina, I have repeated issues or damage to the heart, but it's never necessarily enough to have a heart attack versus a heart attack itself. If you have a chronic issue of just having repeated, anginal episodes, you can have a lot of heart damage, a lot of damage to the actual muscle of the heart, even if it's not necessarily a heart attack, just like a one-off thing. So it can have sometimes a similar presentation, but it's going from a chronic perspective. In this case, for example, these repeated cases of it says in small percentage of patients, continued renal deterioration leads to progressive CKD. So this is basically saying, okay, you could have had like an episode of where this is happening. It's a problem, obviously, but if you have these repeated episodes of something like this happening, it can lead to a chronic condition. Other causes of intrarenal AKI include acute tubular necrosis, which is caused by severe renal ischemia or toxins and medications that damage the tubular epithelial cells. If the damage is not too severe, some regeneration of the tubular epithelial cells can occur and renal function can be restored. Post-renal AKI is caused by obstruction of the urinary collecting system anywhere from the calyces to the outflow from the bladder. And one of the things I would say, again, back into this is saying, this is the post-renal AKI versus some other kind of AKI, like intrarenal AKI. I would definitely focus on just understanding how the kidneys function and like what the step-by-step process of the flow of urine and blood and so forth, just so that you can understand what they're talking about, so you can kind of get a grasp of how all these things are connected to each other. Anyway, back into it. Important causes of obstruction of the urinary tract are kidney stones, which are caused by precipitation of calcium, urate, or cysteine. Chronic kidney disease is often associated with irreversible loss of functional nephrons. Serious clinical symptoms of CKD often do not occur until the number of functional nephrons fall to at least 70% below normal. The maintenance of normal plasma concentrations of electrolytes and normal body fluid volumes occurs at the expense of systemic compensations such as hypertension, which over the long term can lead to additional clinical problems. Okay. And let me just check something. Okay, there we go. CKD, like AKI, can occur because of disorders of the blood vessels, glomeruli, tubules, renal interstitium, and lower urinary tract. So basically, any part of the entire system can lead to a CKD or an AKI. There's not necessarily like a region where it's like off limits or something like that. Any of these things can cause one of these problems. Despite the wide variety of diseases that can cause CKD, the end result is essentially the same, a decrease in the number of functional nephrons. Chronic kidney disease may initiate a vicious circle that leads to the end-stage renal disease. I would prefer the term vicious cycle, but, whatever. In some cases, an initial insult to the kidney leads to a progressive deterioration of renal function and further loss of nephrons to the point at which to survive. A person must receive dialysis treatment or undergo transplantation with a functional kidney. This condition is referred to as end-stage renal disease. The causes of this progressive injury are not known, but some investigators believe that injury may be related in part to increased pressure or stretch in the remaining glomeruli that result from adaptive vasodilation or increased blood pressure. It is believed that the increased pressure and stretch of arterioles and glomeruli eventually cause sclerosis, that is to say, replacement of normal tissue with fibrous tissue of these vessels. These sclerotic lesions eventually obliterate the glomerulus, leading to further reduction in kidney function and a slowly progressing vicious circle that terminates in end-stage renal disease. And again, I want to go make a comparison again to the heart, for example. With the heart, let's say you have congestive heart failure. There's a normal compensation mechanism for this issue, but if you actually have a heart failure that's progressing and getting worse and worse, what's happening is that your body is trying to compensate for it, but eventually the compensation mechanism is itself a vicious cycle that winds up killing you, essentially, right? The body is saying, oh, we don't have a high enough blood pressure, we need to go increase aldosterone, we need to do this, we need to do that. And the actual concept, now it can lead to short-term accommodation, and in fact, if it's not too severe, it could probably compensate appropriately. But if you have a chronic problem, if you do have CHF, it can progress eventually and become a vicious cycle that kills you. And the kidneys are no different in that sense. The kidneys have their own compensation mechanisms where they have vasodilation to compensate and stuff like that. But eventually, those compensation mechanisms are not a good solution long-term or with enough damage to begin with, and it eventually will spiral out of control and also lead to, these more severe consequences. Among the most common causes of end-stage renal disease are diabetes mellitus and hypertension, which together account for more than 70% of all cases of CKD. Some of the general causes of CKD are as follows. Injured renal blood vessels. Some of the most common causes of renal vascular injury are atherosclerosis of the large renal arteries, fibromuscular hyperplasia of one or more of the large arteries, and nephrosclerosis, a condition caused by sclerotic lesions of the small vessels, and glomeruli that is often a result of hypertension or diabetes mellitus. Injured glomeruli, one example is chronic glomerulonephritis, which can be the result of several diseases that cause inflammation and damage to the glomerular capillaries. In contrast to the acute form of the disease, chronic glomerulonephritis is a slowly progressive disease that may lead to irreversible kidney failure. It may be a primary kidney disease occurring after an acute glomerulonephritis, or it may be a secondary to a systemic disease such as lupus erythematosus. So SLE, Injured renal interstitium, primary or secondary disease of the renal interstitium is referred to as interstitial nephritis. This disease can result from vascular, glomerular, or tubular damage that destroys individual nephrons, or it can involve primary damage to the renal interstitium caused by poisons, drugs, or bacterial infections. Renal interstitial injury caused by bacterial infections is called pyelonephritis. This infection can result from bacteria that reach the kidneys through the bloodstream or from More commonly, ascension from the lower urinary tract through the ureters to the kidney. With long-standing pyelonephritis, invasion of the kidneys by bacteria not only causes damage to the renal interstitium, but also results in progressive damage to the renal tubules, glomeruli, and other structures, eventually leading to loss of functional nephrons. Okay. Nephron function in chronic kidney disease. Loss of functional nephrons requires surviving nephrons to excrete more water and solutes. The kidneys normally filter about 180 liters of fluid each day at the glomerular capillaries and then transform this filtrate to approximately 1.5 liters of urine as the fluid flows along successive nephron segments. Regardless of the number of functional nephrons, the kidneys must excrete the same volume of urine if intake is constant to maintain fluid balance. The loss of functional nephrons, therefore, requires the surviving nephrons to excrete extra amounts of water and solutes to prevent serious accumulation of these substances in the body fluids. This is achieved by increasing the GFR or decreasing the tubular reabsorption rate in the surviving nephrons. These adaptations allow water and electrolyte balance to be maintained with little change in extracellular volume or electrolyte composition, even in patients who have lost as much as 70% of their nephrons. Well, that's pretty impressive, I have to admit. In contrast to the electrolytes, many waste products of metabolism, such as urea and creatinine, accumulate almost in proportion to the number of nephrons that have been destroyed. So not so fortunate in that case, I suppose. These substances are not avidly reabsorbed by the renal tubules, and their excretion rate depends largely on the rate of glomerular filtration. If the GFR decreases, these substances accumulate in the body transiently, increasing the plasma concentration until the filtered load GFR times plasma concentration and the excretion rate, urine concentration times urine volume, return to normal, which is the same rate at which the substance is either ingested or produced in the body. So basically, it creates a new normal for itself when you destroy nephrons. Some substances, such as phosphate, urate, and hydrogen ions, are maintained near normal until GFR falls below 20 to 30% of normal. Plasma concentrations rise thereafter, but not in proportion to the decline in the GFR. In the case of sodium and chloride ions, their plasma concentrations are maintained at a virtually constant level, even with severe decreases in GFR. This effect is accomplished by greatly decreasing tubular reabsorption of these electrolytes. Plasma concentration, creatinine urea, and just saying, okay, creatinine urea, phosphate, hydrogen ions, and then sodium and chloride in the bottom. It says glomerular filtration rate, percentage of normal. And so, basically, as you can see, when you have 100% filtration rate, everything is in normal limit, everything is typical. But the worse and worse your filtration rate is, the lower the GFR actually is, sodium and chloride are going to stay basically normal. They're not going to really change at all. The body can accommodate for that pretty well. Hydrogen ions and phosphates are going to, be elevated than what they would be typically. And you really start noticing that at least starting off at maybe below 50% GFR from normal. And you really start seeing it really pronounced, maybe below 25%. Just based off this graph, I can't say for sure as a person. I've not read the relevant research on this per se. I'm just using this physiology textbook, of course. And in the case of creatinine urea, it is a lot less compliant. The body is a lot less capable of actually accommodating for it. As a consequence, you start seeing the beginning of the divergence, maybe about below maybe 70% or something like that, and it really starts becoming pronounced. You can see here. They said below 30. They said below 30, I think. So that makes sense. That does seem to be pretty divergent at that point. So it's just something to be aware of. Not all substances are going to have the same reaction when you have impaired glomerular filtration. So it just shows you the names right here. Yeah, of course. Okay. And oh, there we go. Okay. Okay, let us proceed. Effects of renal failure on the body fluids, uremia. The effects of renal failure on the body fluids depends on the food and water intake and the degree of kidney function impairment. Assuming that intake remains relatively constant, the following important effects of renal failure occur. Water is retained and edema develops. Increases in extracellular fluid, urea, uremia, and other non-protein nitrogens, azotemia, occur. The non-protein nitrogens include urea, uric acid, creatinine, and a few less important compounds. These substances in general are the end products of protein metabolism. Acidosis results from failure of the kidneys to rid the body of normal acidic products. The buffers of the body fluids can normally buffer 500 to 1,000 millimoles of acids without lethal increases in the extracellular hydrogen ion concentration. Each day, however, the body normally produces about 50 to 80 millimoles more metabolic acid than metabolic alkali. Complete renal failure, therefore, leads to severe accumulation of acid in the blood within a few days. Anemia occurs because if the kidneys are seriously damaged, they are unable to form adequate amounts of erythropoietin, which stimulates bone marrow to produce red blood cells. Osteomalacia occurs because with prolonged kidney failure, inadequate amounts of the active form of vitamin D are produced, causing decreased intestinal absorption of calcium and decreased availability of calcium to the bones. These conditions lead to osteomalacia, in which bones are partially reabsorbed and become greatly weakened. Another important cause of demineralization of the bones in chronic renal failure is the rise in serum phosphate concentration that occurs because of the decreased GFR. The higher serum phosphate level increases binding of phosphate with calcium in the plasma, decreasing the serum ionized calcium, which in turn stimulates parathyroid hormone secretion, increasing the release of calcium from bones and further demineralization. So I would contend that's a pretty good example of how the entire, what did they say? They say, oh, the body is a unit, that kind of thing. The entire body is interconnected, and as a consequence of that, you're going to run into this situation where if one thing goes wrong, like seriously wrong, the kidneys go wrong, the heart goes wrong, it could turn out really badly for the rest of the body. And not something you would necessarily want to see. So that actually concludes our chapter. So if you like the video, smash that like button and everything like that. Of course, I'm just doing this in part because I have to anyways, and I just figured somebody else might appreciate the reading itself. So if you stuck around for the end of the video, thank you very much, and thank you for watching.